Welcome to Joint Effort PAs, where two orthopedic surgery PAs get real about life in medicine. From tips and tricks to professional growth, work-life balance, and everything in between. We're here to share what we've learned and what we're still figuring out. Let's get into it.
All right, are we recording?
Yeah,
Oh, okay,
it's
right.
happening.
Okay,
now.
sorry. Okay, I'm here. I'm in. Mic is on.
It has been. I mean, not this whole time. So
Okay, perfect.
Our pre-recordings are still safe.
They're sacred. They're locked away somewhere.
Can't be bought.
Content. It cannot be. Not yet, at least.
Uh-huh.
All right, Hannah. How was your week this week?
It was okay.
Okay.
It was
a 5?
emotionally taxing.
Yeah.
It was like a 4 minus. Yeah. But next week's another week.
Yeah.
We'll say that.
Yeah.
I will strive to be better.
Okay.
Yeah.
Always good goals. Mine was also mediocre. I don't really know what else to say other than that. I got a couple staff members turning over and a couple good leads on new providers, so that's good. But again, just in the sitcom of our lives, this was mediocre.
Yeah, mediocre. The week of the doldrums.
Yeah.
Yeah. So yeah, something equally as mediocre.
As boring. I know. We're gonna mediocre is a good transition.
Yeah, we're gonna transition into something quite mediocre, but it isn't mediocre.
No,
and that's the point.
No, this is going to be very, very, very helpful for any orthopedic PA that is new or that doesn't really have a wrap on how to talk about patellofemoral pain. So patellofemoral pain is a diagnosis we love to hate, and also the patients we love to hate. That's pretty accurate, right?
Yeah. It is one of those things that sees you a lot, and explaining it is so challenging. Obviously, coming up with a plan that works is very challenging, and it just continues to plague you. These are the people that no matter what you do, they keep coming back and they're like, nothing is better. And you lose things to offer them. Yeah.
I see this a ton. And I do think I do a really good job at explaining what this is. And it's always a kid or a 45-year-old female and their parent. That's what's so hard because the parent comes in wanting answers. Like they, metaphorically and literally have a notebook of here's what we tried. Before I even talk, they're like, I'm going to save you some time. We've done this, we've done this, we've done this, we've done that.
And you're like, wow, you've done everything I was about to offer you.
Yeah. And I really do think I do a good job with this because I've had, a very beginner conversation. Then I've developed that and I really think I do a good job, but I got a 2 rating in the month of May. No comment, no nothing. It was a drive-by shooting. That's what it felt like. Yeah. I don't know who it was. Someone robbed me and I just wow, where's my wallet? That's it. I'll just have to move on.
Now. Yeah. You can't call the sheriff to find out
I can't call the sheriff. No. And I normally can need the person who looks at this stuff. And I did. And they were like, nope, no comment. Let me know if you need anything else. I'm like, I need you to be a detective.
Closure.
I need closure. So I think it had to have been on a patellofemoral pain patient because those ones I think are the most dissatisfying visits for everybody.
Side note, not funny. Maybe it will be funny, but the amount of time we spend reveling in these things. What if the person just got the thing and accidentally hit the 2 on their phone and was scrolling through things and whoops. And you're sitting here for hours who said that?
I know, but wrong? I feel like the people who give you a 1 give you a scathing remark. They just do because they got stuff to say. The person who gave you a 2 was basically a fuck you. They just slashed my tires.
They were like,
here, sit on that. Yeah. Anyway, so I think, and you can relate in the hand world, but this is a diagnosis that I see a lot of. It's so abstract. Patients have pain with patellofemoral pain, anterior knee pain, generally not injury related. It is bilateral, but sometimes unilateral. They've seen X amount of providers. They're coming to you with hope because everyone's told them, quote, nothing's wrong. They've had all the tests. They've had an MRI. They've had an X-ray. They've tried PT. They've tried home exercises. They've invested in braces. They have the skin outbreak from all the taping. They already come in telling you that they've tried all the things that you're going to suggest.
Yeah.
But we see this God, I wish I had the data on percentage
of how much we see
it a lot. We see it a lot.
So this presents as like what the typical person, like you said, female in their 30s, 40s, or a kid, typically female.
Yeah.
Anterior knee pain.
Yeah.
Like vague anterior knee pain.
Yeah.
You know, this isn't like your typical, because the other differentials you can think of this, especially with kids, like Osgood-Schlatter or Sinning Larson-Johansson, like not those things, not very clearly defined, just vague achiness.
Yeah. So, I mean, a lot of primary care will call this growing pains, and then that appeases the parents until the kid stops growing.
I would argue growing pains would more be like, you would say that as far as Osgood-Schlatters or something.
Yeah.
Like,
but growing pains comes with like, hey, you're growing, so just live with it until you're done growing. And then when they come to us, they're done growing. They're like, oh, yeah, now what? But the questions are like, why is it so simple? Like, I'll study patellofemoral pain, you know, like before boards, whatever. Boom, done. 2 seconds. Anterior knee pain, conservative treatment. Next. But why is it simple on paper, but so impossible?
Like, I think it's because nobody's figured it out yet. So like the textbooks don't even know the things.
I think like very difficult, like cancers, which this is a cancer in my life.
Yeah.
I think it is multifactorial treatment. And I say those words like there is not one thing. I don't have a packaged up pill or one answer that's going to fix you. It's going to be a lot of things, and we need to figure out what your formula is. Like what is the combination of things and in what order to get you out of this syndrome. But the visits are long. They're like emotionally long.
Yeah.
I like to go in with direction, because if I don't, then I'm like all over the place. Yeah. And then when they don't improve, like before I go in for the follow-up, I'm like, please be better, please be better. And they're like, no. And then I'm like, but like a little, like I'll try to like bait them, you know? And then it makes me feel like I don't understand it, you know, because there's got to be something else. And I teeter for some of them. And again, take all the patellofemoral pain patients, those that we operate on are such a small amount. And again, we'll go through like contraindications and indications. I want to offer them surgery. I do, but they never get better.
Yeah.
And they want me to too. They want me to also offer that for them.
Yeah. But like, I think, and I will make this akin to like ganglion cysts, my cancer. You know, they come to us after they've already had it drained. They've had it this, that, bracing, whatever, and they just want it removed. And the people who get their dorsal ganglion cysts removed still complain of dorsal wrist pain after the cyst is gone. And then like, oh my God. And then what about when it comes back? If it comes back, terrible.
You said I gotta fix it. It won't come back. Yeah.
Well, I never tell them that actually. And we can get into our spiels, but I bet it's probably similar to yours if you get to the point of surgery where you are very strong with the wording of, hey, there's a chance that nothing changes.
Yes. Yep. So patellofemoral pain, let's talk about the fact that it's called a pain syndrome. It's like dorsal wrist pain. It's not a fucking diagnosis.
Yeah.
Patellofemoral pain is
like
it hurts you. Yeah. It hurts you in the front of the knee, and like runner's knee, anterior knee pain, patellofemoral pain, jumper's knee, all of those things are dumb.
Yeah.
It doesn't tell the patient what's wrong. Yeah. My 20-minute conversation attempts to tell the patients what's wrong, but I mean, the diagnosis sucks. So again, if you have a meniscus tear, ACL tear, arthritis like that, I can take out a model. I can show you what that looks like. Yeah. I now draw pictures with patellofemoral pain. Yeah. But depending on the receiving audience, sometimes it works, sometimes it doesn't. But yeah, patellofemoral pain, your knee hurts because of the way you are.
Yeah. You exist in a world where your knee hurts.
Yeah. So I will address the things like, I understand you've been dealing with for X amount of years. I understand that you've probably been told you'll grow out of it, or there's nothing wrong. But it is a thing. I will say, like, this is a thing. This is a really hard thing. We see a ton of this. Traditionally, the things I want to tell you, like what my textbooks tell me, aren't the right things. Yeah. You know, and I will try to talk about these nitpicky things that I've used in the past that will help. And I know the patients haven't tried it. But anyway, then they're like but let's
supplements and stuff.
Yeah. So they're like, let's go over the MRI. Always 100% of the time, pull up the MRI scan, and they find something to latch onto. Yeah. So like excessive lateral pain syndrome. Ooh, Hoffa's fat pad impingement. They're like, well, can't you take that out? Like, I mean, you can, like, you can
Will that
debride
fix
that. You can do a lateral release, but like, if your quads and your hips and your glutes and your VMO don't work, you're gonna be right back here, but they want something, and they'll go to another doctor to see if they'll fix that something. But the MRI often says maybe chondromalacia, probably not, fat pad edema, maybe some maltracking. And the radiologist says it in such a stupid way, like lateral impingement of Hoffa's fat pad, sometimes seen in maltracking syndromes, right?
Yeah, and
so
you're
then,
like, great, you fucked me over by putting that
or
report in.
It'll say no internal derangement, or it will say no abnormal findings, or completely unremarkable MRI.
So unremarkable, it's disgusting.
But I will, and that's a good like leading point, because I'll say to the patient, let's talk about it, and I will go through the whole thing of all the forces that pull on the kneecap, how in females when you're growing the Q angle down to the knee, if there's no if there's no glute control, your knee's gonna hurt.
Yeah.
The end.
Yeah.
If you're a multi-sport athlete, your knee's going to hurt. If you're a single sport athlete, your knee's going to hurt.
Yeah.
And all these patients
if you're not an athlete, your knee's going to hurt.
Especially if you're not an athlete. But most commonly seen in females, most commonly seen in those that have some degree of underlying hypermobility, whether it's like real, like an EDS variant, or just familial and not, diagnosed.
What about those EDS patients when they're like, I have EDS, and like they told me, I feel like we've gone into this before, that like I can't get into a geneticist, and you're like, well, I don't like they're going to do anything different for you. Like they might tell you and write on a piece of paper that you can see in your chart that you have this diagnosis, but like they're not going to, they don't have a magic fix.
I have a 45-year-old female that I saw her daughter, spoiler for Patellofemoral Pain Syndrome. And then she was like, oh my God, you explained that so well. Like, I'm going to transfer my records and I'm going to see you.
And you're like, nice.
Yeah. She's like, no, but listen, so this doesn't surprise you, right? I've had 4 surgeries on my left knee and it still hurts. No surgeries on my right knee. I'm getting my labrum and my hip repaired next week, which, by the way, that probably was not torn. That's probably just like MDI in the hip. Yeah. And so I see her. I know what she wants. She wants MRIs. I get MRIs. The right knee or whatever knee she had 4 surgeries on shows that she had 4 surgeries on her knee. The left knee, completely unremarkable MRI. Called her to go over the results, and she was very disappointed I was not suggesting surgery. And then I will say to the patient, what are we going to fix? Like, what are we going to fix?
So side note, and I like don't like to be this person, but we'll be this person because everybody thinks this. We're going to say it. What is the association between this, you think, and like psychological factors? Because I try so hard to like not lump these things together. Like, part of this is just like there's a psychological component to vague anterior knee pain, just like there is vague ulnar-sided wrist pain.
Yes.
And I like it does exist because, again, there are pathologies that cause this. There are surgical fixes and indications sometimes for these things. But there are also people that just don't get better no matter what you do. And like, is it something we're all just completely missing, or is there a psychological component to it? Is there like a thing with people not like intolerance to mild discomfort that in some populations people don't like know, like, I picked up my coffee mug this morning and my wrist kind of like twinged and hurt.
Yeah.
And like, my wrist just twinged because I grabbed it weird. I don't know. And then somebody who is going to seek an answer and like a fix to never feel that because that's abnormal.
So I will tell you, on my team, when we do ACL reconstructions, we went through a time where we had everybody fill out a grit score.
Okay, like quick dash for
It was called a grit score. I have to find it on my computer somewhere. But anyway, like when I start a project, I finish it. Sometimes, never, always. Like, okay,
like
so
this.
that gets down to, I think, what you're asking.
Yeah.
But to answer your question, patients with patellofemoral pain often have higher rates of anxiety, depression, pain, catastrophizing, fear of movement, hypervigilant to symptoms, and stress-related pain amplification.
Yes.
Like facts.
Yeah, no, that's facts. Like believe those things.
Compared with asymptomatic cohorts, these factors are associated with higher pain scales, greater disability, lower quality of life, and worse outcomes after rehab.
Yeah, absolutely. Facts. I mean, because I think somebody could have the same, patellofemoral instability issues, and one person just ignore it and tolerate it and live their life just fine.
Yeah.
And my knee hurts sometimes when I do these things, and it crunches a little when I walk up and down the stairs, but whatever.
Yeah.
And then the other person who has had 5 surgeries because of it and is hyper fixated on it. And so that nothing is going to make that.
So
100%.
Other interesting fact is that patellofemoral pain often affects high achieving personalities, such as runners, athletes, dancers, highly active individuals who are often goal-oriented, perfectionists, and frustrated by limitations. You know exactly the patient I'm talking about. Where they feel it, my knee clicks, my other one doesn't. Why? Fix it.
Yeah.
I can't have this clicking. Yeah. Well, does it cause you pain? No, but it clicks. But it feels like it will click.
Yeah.
So the uncertainty of will it, won't it, sometimes is more psychologically distressing than the pain itself. Or like the 13, 14, 15-year-old female who's in gym class and they're asked to sprint and they feel something funny, therefore they abort. And then it results in, oh, you can't complete this. Oh, you must sit out. Like there's certain factors that go into that.
So interesting to me.
Yeah. So are there certain psychological factors? Yes. I think these patients generally have lower pain tolerance. Yeah. And when you give them an abstract diagnosis and pair it with that, it's like a recipe for disaster.
Yeah. And that's really hard that you can't really get into that side of things with it.
Yeah.
Our job is to diagnose a very clear problem, and here is the injection and or surgery and procedure that will fix it for you.
I'll tell you what, I can't inject weak quads. I can't inject tight lateral, tight iliotibial band. I can't inject, quad weakness.
Yeah. You can't inject peptides.
I can't. Can I? But no, I will focus on these visits. I will explain to the patient there's extra stress on the joint, all of the factors pulling on your joint. If there's a little maltracking, a little bit of quad weakness, your IT band's a little bit tight, and you're pairing that with overuse, overactivity, and your skeleton is growing, that's the perfect formula for exactly what you're feeling. Pair that with your abductors are weak, your glutes are weak, your core is weak, you're overpronate when you walk. That's crazy. Now, you've chosen volleyball where you jump and you land, You've also chose to be a runner where you're excessively running up and down hills. You also chose to wear your Hey Dudes all day. There's all these things, and I will go over every single one of these things. But again, it's so draining. I don't know.
It is draining.
And here's the other thing. And again, for our athletic trainer / physical therapy friends, they suck at it. That is a blanket statement. And I will defend that. Physical therapists suck at patellofemoral pain because they treat it all the same. And I think you have to know the patient, know what their psychological issues are, and slowly bring them up to speed as far as what your plan is. I will tell patients, I'm going to schedule you a 6-week follow-up, and we'll do a 6-week follow-up after that. You may have no improvement in your symptoms over that period of time. You need to buckle in. This is going to be a project more so than hey, you'll be cured in 6 weeks. So I don't know. And again, I'm generalizing. I don't know that the physical therapists have that long conversation, especially when they're medicated and they only have 6 visits for the year. So
that's tough. Yeah, if there's any PTs out there who specialize in patellofemoral
oh my
pain,
God. And if you don't, I think that is a huge opening. If I had a patellofemoral pain guru that I can send people to, that would be amazing.
We need the patellofemoral guru.
But I think though, in treating these patients, you have to think outside the box. If you were to Google right now, how do you treat these patients? Physical therapy, corrective shoe wear, NSAIDs, avoiding activity, return to activity tolerance. You can tape them, you can brace them, whatever. Yeah. And it's not something that keeps you out of sport. But if you see this kid has been dealing with it for 3 years and their parents are but they can't be a swimmer. You're you can, you just have to decide with how much you want to deal with. But I will tell them there's no thing, I can't package up a thing and give you a pill or give you a shot. But again, is it their back? Look at their hips. Are they hypermobile? With female athletes, maybe we do more than one sport to fix
balance
if you're doing balance things out. Yeah.
And these are usually your hamstring dominant athletes.
Yeah.
Yeah.
And I will have, one of my key moves is I'll have the patient in the room step up on the stool and try to do like a heel tap, like a really low, what are they? They're 12-inch stools. And they'll, toe tap, no problem. Most of them can pop that out. But if you really try to do a heel tap, almost like you're doing a pistol squat kind of, you will see their knee completely valgus. And I'll have the mom stand behind me. I'll be like, you see this right here?
Yeah.
This is what's going on. And I had a really good visit, which hopefully wasn't the two, last week, where the mom was like, oh my God, I see that. And I said, listen, you know what that tells me? You need to work on your glutes. And she goes, oh my God, if I had $1 for every time one of my coaches told me that. And I was like, but that's why we're here. That's why we're here.
Like,
and God forbid you talk about their weight.
Yeah, it's a touchy subject.
It's a touchy subject. Like I will say that, I will say we need to, optimize. I don't think I'll say the word weight. I think we need to optimize,
body habitus.
Your body habit. Oh God. Panis. Words that I hate when they hit my ears. No. Yeah. And I will admit the shortcomings. I will say, we should have a better answer for you. There should be an injection that will fix you. I should have a physical therapist where I can package you up and send you to, but it's just not that easy, unfortunately.
But I think at least, like, this is my hope with these types of visits, that these patients feel like you are just as frustrated as they are with the condition and the treatments and whatnot. And I think it's a more in-depth visit than just looking at something and be like, oh, well, like the MRI is negative, x-rays are negative, NSAIDs therapy, that's all we have to offer this. That's something very easy to do. But if you want to level up, then you're looking for these other things.
Speaking of leveling up, I've created a document that is core values patellofemoral pain.
The core values of patellofemoral pain.
Yeah.
What are the core values?
Okay. So how can this affect you in different stages of life? And again, it gives in the beginning, patellofemoral pain describes pain in and around the kneecap. Wah, right? How patellofemoral pain can affect you at different stages of life, because I'll see this, teens and 20s, overuse, muscle imbalance during growth. 30s and 40s, repetitive movement, long hours of sitting or standing, like unfortunately, and things uncorrected in your teens and 20s. 50s and 60s, now you're adding in cartilage wear, sarcopenia, another word that makes your ears want to bleed, or previous injury. And then 70s and beyond, joint stiffness, arthritis, reduced activity tolerance. I mean, it affects everybody. Yeah. What does it say? At our practice, patellofemoral pain takes a multi-treatment approach. Healing takes time, patience, and consistency, and your feedback is essential as part of the process. Physical therapy, home exercises, power plate, vibration plate protocol, that's huge for simultaneous glute and thigh activation. Outside the box, red light therapy, laser therapy. We talk about bracing and taping, foot and ankle alignment, anti-inflammatory support. The core values of recovery: patience. This is not days, it's weeks to months. Consistency, regular exercise and therapy builds results. Communication, share what's working and what's not working with your team. Teamwork, your provider, your therapist, your parents, and progress, not perfection. Small improvements lead to lasting results.
This is like, perfecting your position in a sport. This is like, making some sort of 1 rep max gain. Yeah. It's not this is the issue, take it out, do this and fix it. It is let me build myself differently.
Yeah. Yeah.
And that takes years.
But that's really hard for the teenage population to hear. The parents kind of are like, wow, it's never been explained to me that way. And I kind of get it now. Yeah. But then taking your 15-year-old and you're like, hey, so when you tell me that you don't want to go to therapy because you want to go hang out with your friends, like, then I don't want to hear that your knee hurts.
Yeah.
But anyway.
And I think depending on the parent too, you may have a very different type of conversation. There's some parents that are like, no, like, if this is the issue, I agree with you. Yeah. We need to be consistent with it. Like, if you want to feel better, you have to do your therapy. And then there's some parents that are like, why aren't you fixing them? Like, you're doing nothing.
But take home, and why this is so goddamn frustrating, is that patellofemoral pain is less about fixing a knee and more about managing the patient.
Yes.
Managing their expectations is really hard.
There's a lot of things like this. I think there's a multitude of conditions that are akin to Beth's cancer of the knee, where you don't have like a black and white quick fix answer for them.
But I'll tell you what, early arthritis, not patellofemoral, but otherwise in the knee, that falls in this category. Patients that have posture-related shoulder impingement, that falls in this category.
Yep.
Patients that have not really diagnostic cervical pathology, but have shitty-ass posture, that falls in this category.
Yeah, like with all that vague upper tract pain, medial scapular
pain.
Yeah, medial scapular border pain and like scapular dyskinesis. Ooh.
Yes, yeah.
Ulnar-sided wrist pain.
Ulnar-sided wrist pain.
Dorsal ganglion cysts.
Dorsal ganglion cysts, yeah.
I don't know anything about feet and ankles, so I don't know what the cancer of the ankle is.
I think metatarsalgia, that's another one. That's all like a mechanical thing.
Okay.
Yeah, that's it.
Yeah.
Anyway.
So I think take home is get good at personalizing treatment plans for it and have a good explanation for why you do what you do for these things, because otherwise I think early on in your career you go into these conversations like having the basics, the black and white answer, and then when the person looks at you and is like, but I tried that, what next? Well, now you're deer in headlights.
Yes.
Like,
so that's also the worst. So like, you know, if textbook says or experience says or your mentor doctor says physical therapy, like ask a physical therapist, are you dry needling their IT band? Are you doing blood flow restriction? Have you looked at their glutes? Are you doing anything with their feet? You know, like, I mean, stuff like that. Force plate them. See exactly what about their running, jumping, landing is the problem. Yeah. So I think as a provider, you have to be a little bit more curious and a little bit more dedicated to figuring this out for each patient. It is frustrating. There's a lot of this is normal. This is normal. Their physical exam is generally pretty normal.
Go more in depth and level up, because I'll tell you, like from a PA perspective, this is typically, these all lump into the category of typically non-surgical problems. So you need to be the one that's best at managing these things. Your doc, your surgeon doesn't want to see this shit on their schedule. They don't want to deal with that. Like they shouldn't be dealing with that.
Yeah.
You are going to be the ringleader of these difficult problems. Like that is your specialty.
And I think a key though is also don't tell them, hey, if it doesn't get better, come back and see me, because you also are then telling them you're dismissing them. I always schedule these people follow-ups of like, hey, let's have an appointment in 6 weeks and let's see what's worked and what hasn't worked. And we'll go from there. I think once they feel like you're bought in, then they're bought in. But if it's kind of like, all right, PRN follow-up, like, you know, that's not great. So you got to own it. You got to do a better job. The patient population's tough. They're going to look at you and question you, but it's part of what we do.
This is about leveling up.
Yeah.
Yep. This is about getting better.
Thanks for tuning in to Joint Effort PAs. If you enjoyed this episode, be sure to subscribe, leave a review, and share it with a fellow PA or med-minded friend. You can also follow us on Instagram at Joint Effort PAs for updates and extra content. See you next time.